Good afternoon. Welcome everybody. Thanks for joining our webinar for today. My name is Cynthia Peña. I manage the CDAP Sweet Success Resource Center. So today's presentation is Insulin and Oral Agents for Management of Diabetes in Pregnancy. Our presenter today is Dr. Sandy Ramos from the UCSD Medical Center, and I am going to let her tell you more about herself as we switch out the presenter screen.
This is Sandy Ramos. I'm one of the associate clinical professors in the Division of Perinatology at UC San Diego Health System. I'm also co-director of the Diabetes in Pregnancy program at UCSD. I wanted to thank Cynthia for the opportunity to give this talk today. Here's a brief outline of my talk. We're going to be discussing glycemic control goals, insulin therapy in both type 2 diabetes patients as well as gestational diabetics and type 1 diabetics, and also we'll be ending our discussion on oral hypoglycemics. I want to just apologize. I am recovering from a cold, so I may be coughing and my voice may sound a little raspy as we go forward. I wanted to let you know that I have no conflicts of interest. I did want to review with you that we will be reviewing both the California Diabetes and Pregnancy Program guidelines as well as some UCSD practices which may differ from CDAP guidelines, and I'll be clear and let you know some of those differences. So we'll start our talk with glycemic control. As you all know, our target values are to maintain a fasting of less than 90 and a 1 hour postprandial value of less than 130. Some of you may also be using a 2 hour value of less than 120. Really, the main reason to adhere to these glycemic control targets are to minimize adverse neonatal outcomes, the main one which is the development of macrosomia as well as the development of neonatal hyperinsulinemia. However, I must be honest that there's data lacking in regards to which is most important. Is the fasting more important than the 1 hour or 2 hour postprandial? And really, in my mind, maintaining good glucose control with all of these factors in mind is important. So where did we get these goals? Well, this is a nice study that was performed by Dr. Peretti, which is published in the textbook by Dr. Creasy and Resnick, and my mentor, Dr. Moore, writes the chapter on diabetes. And as you can see in this figure, here you have the plasma glucose value, and here you have in the x-axis the time of day. This was a study that was performed on non-diabetic women at 28 weeks, 32 weeks, and 36 weeks of gestation. And as you can see, if you look at the fasting values here at around 6 to 8 a.m., most of the women did not have a fasting of greater than 80. And if you look at the postprandial values, they tend to be lower than 110. And so what we're really trying to achieve with these glucose control targets are to normalize the glucose metabolism or simulate a normal glucose profile. And that's what we're trying to achieve, and that's what I tell my patients. So if you consider our targets, they actually allow for a little bit of a cushion in patients with diabetes. So what is the physiology that we should expect in pregnancy? This is a figure demonstrating what we expect to see as we progress during pregnancy. Again, in the y-axis you have insulin doses, and this is actually units per kilogram. And in the x-axis you have gestational age. As you can see, we start at point 0 at 0 weeks of pregnancy, and then we hit a nadir in the insulin requirements. That usually happens in the first trimester. I usually note that there is a decrease in insulin requirements by as much as 15% early in the first trimester. Then we see a flattening of sorts of insulin needs as we progress up to about 14 to 15 weeks. And then we see a linear increase in the insulin requirements during pregnancy, typically peaking at around 34 to 36 weeks, and then we see a decline in the insulin requirements. We have to keep this pattern in mind as we're making changes to patients treated with insulin during pregnancy. So it's important to be aware that insulin requirements increase during pregnancy in type 1 diabetes patients. We just recently published a study looking at our insulin pump patients who were very well controlled in the first trimester with an A1C of less than 7%. And we noted that their insulin requirements may increase as much as 300%, particularly their bolus insulin requirements. Our type 2 diabetes patients may increase by as much as 70 to 100%. And the same thing can actually be seen with our patients with gestational diabetes, and this rise can occur over even a 10-week period. So it's important to address insulin changes every week. Generally speaking, I increase insulin doses by about 20%, which generally translates to about 4 to 6 units increments per injection. And there becomes a time, particularly in the late third trimester, where we're making changes to their insulin dosing 2 times per week. And this is particularly important because we have a metabolic clock that is ticking. This is a nice figure that depicts fetal growth over time. On the y-axis, you have the birth weight gain per week of a fetus, and on the x-axis you have the weeks of pregnancy. And as you can see, by about 22 weeks, you see this linear increase in fetal weight up to about a maximum of 34 to 36 weeks, and then the fetus doesn't stop growing, it just slows down in terms of its growth. And so this is what the time period in pregnancy that we're trying to achieve good glucose control to really affect fetal growth. This is also a nice slide to plug our first trimester screening guidelines that the CDAP has introduced as of 2011, where we screen patients in the first trimester and start treating them quite early. With our old 2-step criteria, we were to do a glucose challenge test around 24 to 26 weeks. Then a week later, a 3-hour confirmatory test to diagnose GDM. A week later, start the class. A week later, start medications. And as you can see, we've kind of missed the boat, if you will, in terms of fetal growth. And so that's why first trimester screening, I think, will have an impact on this. But again, this is a topic for another lecture. So let's move on now to principles of insulin therapy. First, we need to know the types of insulin that we can use in pregnancy and are at disposal. As you can see here, I have them listed in terms of shortest acting to longest acting. The ones in red are the ones that I typically use in pregnancy. So when we look at the short-acting insulins we have at our disposal, Lispro, Humalog, and Novolog, which typically have an onset of action anywhere from 15 minutes to half an hour. And they peak at about 1.5 hours and last only for about 3 to 5 hours. Regular insulin, on the other hand, tends to have an onset of action, in my experience, of about 1 hour. It really peaks at about 2 to 4 hours. And the duration of action is actually longer, lasting 6 to 8 hours. And then we have our intermediate insulin, which is NPH. Again, it has an onset of action of about 1 to 3 hours, but peaks really at around 4 to 7 hours. It may last as long as 13 to 18 hours. And then we have the long-acting insulins. The one that we most commonly see in pregnancy is Lantus. That's the one that most of our patients with type 1 diabetes will come to pregnancy with. I want to point out that it does not have a peak of action, and it actually has a very long duration of action, ranging anywhere from 20 to 24 hours. So how do we calculate the initial dose of insulin? I must let you know that this is a protocol that we use at UCSD. If you look at the CDAP website, you'll see that they use slightly lower units per kilogram of insulin per trimester than we do at UCSD. In general, at UCSD, we use 0.7 to 0.8 units per kilogram in the first trimester, 0.9 to 1 in the second trimester, and 1 to 1.2 units per kilogram in the third trimester. So generally, we weigh our patients, convert that weight into kilograms, and then initiate the insulin based on these guidelines. So in general, here are some tips for what we expect for insulin management during diabetes. If we are lucky enough to get our patients preconception, which as you all know is quite difficult, generally I talk to them extensively about what I expect for them. As you know, most of our patients, particularly those with type 1 diabetes, are not checking their blood glucose values as reliably as they do during pregnancy, and so therefore we have that discussion. I want them to have smooth glucose control, avoiding hyper and hypoglycemia, and have a reliable regimen. I also want them to have an A1C at the beginning of pregnancy or preconception of less than 7% to minimize adverse fetal complications such as the risk of congenital anomalies. As you know, there's a linear relationship between congenital birth defects and an increase in hemoglobin A1C. In the first trimester, I'm cognizant of the fact that I'm going to have to cut back their insulin by as much as 15% up to about 11 weeks, and that it later flattens out to about 14 weeks, where it starts to increase in a linear fashion. And then in the second and third trimester, that insulin needs to be increased weekly or more often. We do review their glucose targets, which are to maintain their fasting insulin 90 and the 1 hour postprandial less than 130. And we generally increase their insulin doses when we see that 3 or more of 7 values are elevated above the target.